All right. So now you know why we do what we do. Is any of this a surprise? Any of these things listed something that you didn't know about? Okay? But did you think about why you were doing it? All right? This is it. Okay? What we do is determined by the indications, the risk involved, and how to avoid, prepare, or treat it. Okay? So that's how these protocols get driven. It's not just because it's a sunny day and so let's do this protocol. All right? So again, it's preparation and the way of thinking about it. All right. So you have to make some assumptions. All right? And especially you guys, because you're going and getting these patients. You may or may not have a detailed history. You may or may not be dealing with the person who was there the entire time the kid was there, okay? So the onus is on you to make some assumptions about your patient in order to minimize and avoid the known risks, okay? So what assumptions do you guys need to be making with each and every patient about the risks, about these things we listed?
Did they like it?
Right, but specifically which ones you have to assume are there, all right, because you may not be able to be sure.
All of them.
No.
Esophageal intubation.
Laryngospasm.
You can probably
But
assume
going
trauma.
into it, okay? Going into it in your preparedness, okay, before you even pick up the blade, what should you assume your patient has a problem with?
Positioning.
Aspiration.
Inadequate oxygenation.
A risk. Risks.
A risk.
Do you know that this is true necessarily
No.
before you pick up every patient?
No.
Okay, that's what I'm talking about. All right, so ICP. If you don't assume your patient has a risk of intracranial pressure, are you going to go above and beyond means to protect them from it? Okay, that's what I'm talking about. You must assume that the patient has increased intracranial pressure unless you absolutely know that that is not anywhere in the realm of possibility. Okay, what else do you have to assume?
Bradycardia.
Well, yeah, in the sense that, once again, just like my paralytic, I always have the atropine dose there, and, you know, we'll talk about that in a minute.
You can monitor that as you're doing it. You know that real time.
Right, but you have to be prepared. Okay, but what are assumptions, okay?
Aspirations.
All right, should we assume that all our patients' stomachs are empty so we don't have to worry about aspiration, so we don't need to really watch our pressures, our positioning, or do the self maneuver? Okay, so we must assume that all of our patients' stomachs are full. Okay, all right, one more.
Assume trauma.
Yeah, all right? So you have got to make these three assumptions that every patient you come up to has the potential for having an increased intracranial pressure. Every patient you come up to their stomach is probably full, all right? And every patient you come up to, their C-spine needs to be protected, all right? Unless you know absolutely otherwise, okay? And I'll tell you, these you'll probably know. This you're never going to know. All right? I mean, who's keeping track of when somebody ate what? All right? And how does mom know that dad didn't give the kid a bottle? All right?
Forget.
Exactly. Or you don't remember that you did it. Okay? So you've got to assume that they all have a risk for increased intracranial pressure. They have something in their stomach, and that their C-spine needs to be protected. Okay? All right. So, what other procedure must we know how to do if we're going to be prepared to treat any known risk? What other procedure must we know how to do?
How to ventilate.
Basic
Basic
airway.
airway.
Somebody said it. Say it again.
Needle
Yeah, needle decompression. Okay, if you don't know how to do a needle decompression and you don't feel comfortable doing it, should you be intubating?
No.
Not technically, okay? If you're doing a procedure with a known risk, the onus is on you to know how to treat it. All right? Simple as that. If you're going to do something to a patient, you need to know the risks, the benefits, and how and what to do to intervene if one of those should occur. All right? Okay? All right. So, let's talk about RSI in general. Okay? So somebody tell me, we talked about how positioning and being prepared is the key. So what do you have to do? How do you prepare your patient? Tell me a sequence that must occur, okay, before you, as you prepare and as you intubate the patient. What do you do first? Assume what 3 things? Okay, all right. So you make those 3 assumptions, all right? So now you do what?
Pre-ventilate.
Okay. All right. You can choose, and it depends on the situation, right? If the child is completely apneic when you approach the bed, is there your first thing going to say, okay, I need an NG, and sit there and wait until you get the okay? So yes, you want to decompress the stomach, but again, it depends on the exact situation. If the patient's apneic or in severe distress, the first thing you're going to do is assist them with that, all right? So.
But you're, at that point, aren't you assuming the risk of not, I mean, you're saying with the risk and benefit, it's better to forego the EEG period.
Okay, what else could you do? Any other possible thing we discussed to prevent aspiration from positive pressure breathing? Okay, when do you do this?
Before you start back.
Before you start giving positive pressure breaths. When do you let go?
When
When the tube is in, okay? All right? That's how it's supposed to work. And I understand that that's not what happens, okay? But that's the theory is you do the self maneuver before you're giving positive pressure breaths, okay? But we all only have so many hands. And once again, you must make a risk-benefit call, okay? So again, the kid's sitting there and the sats are 60 and they're apneic and they're going bradycardic. All right, you use both your hands to get the mask and start bagging. You know what I'm saying? Okay. All right, but technically one person should be doing the self maneuver while the other person is delivering positive pressure breaths. Okay. All right, because if we're talking about rapid sequence intubation, technically, is there time to go get and place an NG tube? Okay. All right, so self maneuver before positive pressure breaths, do your positive pressure breaths, only to buy you time until you are ready to roll, okay? And what's the next thing you're going to do?